I hope you're able to see my screen. You can see my screen, yeah? Okay. Okay, so if I'll be too fast, just let me know. So, how you can understand edema, or rather how it's happening, I want you to think about it from a standpoint of fluid dynamics. So, if this is your blood vessel, there are fluid dynamics that are keeping fluids, let's say in this case blood flowing inside this blood vessel. There's some dynamics that are preventing blood from moving outside and it just to be flowing within this vessel. So think of fluid dynamics from a standpoint of homeostasis. You have a seesaw, and if this seesaw is not properly balanced, you can easily have fluid seeping out of your blood vessel. So this seesaw is representing homeostasis. There'll be two forces that will be regulating your fluid dynamics. On one end you've got hydrostatic pressure, and on the other end of this seesaw you've got oncotic pressure. So when you're thinking about your hydrostatic pressure, you think of forces like your blood pressure, and we know that this will be a product of what? Your cardiac output by your systemic vascular resistance. And ultimately just think about fluid pressure within a particular blood vessel compartment. The amount of fluids there, since we know that fluids, like all things, will exert pressure on the walls of whatever container they are in. So in this case, if you're thinking about your blood vessels as a container, there'll be certain dynamics there'll be certain amounts of pressure that will be hitting the walls of your vessel. Then your oncotic pressure, you think about your proteins. The one to think about the most will be your albumin. So by virtue of that, if you could tie oncotic pressure to any given system or organ, you'll be thinking of the liver and you'll be thinking of the kidney. Why these two specifically? The liver will be responsible in producing albumin. So if the liver has got a particular problem, it means that the amount of oncotic pressure you'll be having will be reduced, thereby not necessarily increasing the hydrostatic pressure, but the amount of force that is counteracting the hydrostatic pressure will be distorted. Say if hydrostatic pressure is 5 kg and your oncotic pressure is also 5 kg, but this time if the liver has a pathology, and let's say the amount of albumin that's there is give or take 2.5 kg. So it's not that the hydrostatic pressure has gained more weight, but it's been counteracted by a smaller load, and so hydrostatic pressure seemingly seems to be increased, and thereby fluids can seep out of your blood vessel. I hope that has made some sense. And lastly, your kidney. So how does the kidney come about? The kidney is responsible for excreting these proteins. So again, if the kidney is excreting too much proteins, think of conditions like nephrotic syndrome or these rapidly progressing nephritic syndromes. So you think of things like, let's say, SLE, lupus nephritis. Someone will have a nephritic picture, meaning they are not just excreting blood in the urine but also proteins, thereby reducing the oncotic pressure. So if you happen to have, let's just say again, nephrotic syndrome, we know that there will be proteins in the urine, so there's loss of proteins. And coming back to our homeostasis, hydrostatic pressure, seemingly now it's as if it has increased in pressure, when in the actual sense the amount of oncotic pressure counteracting it has been reduced. So because of that, when we look at fluid dynamics, you've got your hydrostatic pressure upwards and you've got your oncotic pressure downwards. So let's just say hydrostatic pressure, and you have your oncotic pressure downwards. The oncotic pressure, say this is nephrotic syndrome, the patient has lost proteins. So it means that the amount of force counteracting the hydrostatic pressure has reduced, so fluids can easily seep out into the third space. And when you're looking at the clinical manifestation, when you do your physical examination on a patient with nephrotic syndrome, what you get to notice you get to notice that a patient will have okay, this is an over exaggeration, but you get to notice that the patient has got what? Pedoedema. Why is a pedoedema coming about? A patient with nephrotic syndrome loses proteins. There's loss of proteins where in the urine there's proteinuria. Because of that loss of proteins, specifically, we are looking at albumin, and we know that fluid dynamics in the body, there's a state of homeostasis where you've got hydrostatic pressure on one end and you've got oncotic pressure on one end. Oncotic pressure has reduced, so seemingly it feels as if the amount of hydrostatic pressure has increased, so fluids can easily seep out. If this is your blood vessel, fluids can easily seep out of your blood vessel. So SLE nephritis, your nephrotic syndrome, even when you look at these hypertensive disorders in pregnancy, so you're thinking of things like what? Your eclampsia, your preeclampsia, you get to notice that you have edema, which would be a common feature. So that was on the side of the kidney. On the liver, like I said, the liver produces this albumin, and so a patient who's got liver disease, things like ascites, and if it's really bad, they get an anasaka, which is basically just generalized edema. Again, liver is producing albumin. If there's low albumin, it means hydrostatic pressure is also being affected. Another way, when you're thinking about liver pathologies, so let me just do this. You've got the GI. When you ingest food into your GI, you will get your portal circulation. From your GI, food goes to the liver, where different things can take place in the whole assimilation process. Then from the liver, it goes to your inferior vena cava, and then it goes to the heart. So let's say someone has got liver cirrhosis. Remember the non-reversing or non-scarring. So someone has got liver cirrhosis, and you have blood vessels. Blood, mind you, is moving. So from the GI, things are coming to the liver, from the liver to the inferior vena cava to the heart. And just to briefly branch off, remember when you're looking at things like paracetamol poisoning, metabolism happens there at the liver. So people with, say, liver cirrhosis at risk of having paracetamol poisoning just because of how blood flows. If the liver is being removed out of this, you get to have toxic substances. Think about also things like your hepatic encephalopathy, how it takes place. That's just a reminder. Anyway, that's a topic for another day. So in this case, the liver, there's the liver, you've got your liver cirrhosis. Blood, remember, is flowing through the liver, and let's say because of this whole cirrhosis that's taking place, there's compression of the blood vessels flowing through from the liver to the inferior vena cava. If you remember a bit when we looked at liver failure, we talked about shunting that takes place just because of that narrowing of the vessels passing through the liver. So blood is flowing from the GI, the liver. Let me just draw it this way. If the liver has some sort of pathology, blood will just skip the liver altogether and be shunted towards the inferior vena cava or towards anywhere else. And if you remember, that's how we are getting things like your esophageal varices and so forth and so on. Now, because of this narrowing of vessels that's in the liver, what happens? There's a backload of blood flowing back. And remember what I said, when you're thinking about hydrostatic pressure, you think about your BP, which is your cardiac output, by your systemic vascular resistance, and also just think about the amount of fluids which will be in a given compartment, since fluids, like all things, can exert pressure in the walls of a container. In this case, we're thinking of our blood vessel as a container. So now what we happen to have is narrowing of vessels in the liver, and this build up of blood goes back, and let's say the abdomen. So what happens if this is a normal vessel? Let's say blood or fluids flow like that. Now we have liver cirrhosis, so there's narrowing of vessels. It then means that, so blood is flowing from in this particular direction, and let's say that there's increased pressure or resistance over there. This is the liver. So you would happen to see some sort of bulging of blood vessels. So just to repeat one more time in case I've lost you or maybe I just didn't explain properly. You have blood flowing in. So let's just say this is your blood vessel. That's your blood vessel. Blood is flowing, so this is from your GI and it's heading towards what? The liver. Now in this case you've got cirrhosis that's there, and ultimately you get narrowing of blood vessels within the liver. It means that the amount of force that would be needed for blood to overcome to pass through the liver, it's increased, hence the shunting that you normally see in liver failure. Now because of this increased pressure, it means that there's a backload of pressure. Think of a hose pipe. When the sprout, water is just allowed to move out. The moment you cover the hose pipe with your finger, you get to see that the amount of water will begin to flow with a higher pressure in the outside. I'm sure you've noticed this. Normal physics 101. So this backload of pressure over there is increasing the amount of pressure within this container, in this case within this blood vessel. So what happens? Remember, homeostasis, fluid dynamics are regulated by what? Hydrostatic pressure and oncotic pressure. It's supposed to be a seesaw. In this case, hydrostatic pressure has increased. Remember, you think of BP or you think of the pressure of fluids within a given container or within a given blood vessel. In this case, what you're getting to see is you have an increase in pressure. Why? Because of that resistance that's there in the liver. And so fluids will begin to seep out into the third space. And at the same time, remember that there's liver failure here. And so what you're also seeing is that the liver is not producing enough albumin. So it's more of increase in hydrostatic pressure and reduction in oncotic pressure. So what happens? Fluids will begin to seep out into the third space. And when you look at a patient with liver failure, ascites is a normal thing that you're going to see. Oedema, basically. Why? You're thinking about it from a standpoint of hydrostatic pressure and the reduction in oncotic pressure. And then lastly is just blood pressure. Massive increase in blood pressure, and even let's say someone with heart failure. So remember when we looked at heart failure, we said that you've got left-sided heart failure and you've got right-sided heart failure. So the easy way that I said you can remember is left starts with LL. So left, you think of problems mainly manifesting in the lungs. Rest starts with R. So right-sided, most of the problems you'll see will be at the rest of the body. So things like distended jugular veins, things like edema, ascites will be a common thing. Why? Again, because you are increasing the pressure, the fluid pressure, in a given compartment. So the amount of pressure that's there in a given compartment is also increased. And again, it's also a common thing for you to have multi-organ failure, including liver failure, just because of reduced amount of blood which is flowing. Then, remember, I always tell you that when you think of pathologies to do with the heart, in this case heart failure, don't forget the kidney. Why? Because the kidney has got the RAS system, renin, aldosterone, angiotensin system. Because of this reduced blood supply to the kidney will incorporate this RAS. Ultimately, this RAS will lead to an increase in the amount of water reabsorption, and also at the heart it will increase the blood pressure. So what you end up seeing is that you've got increased fluids. When you've got increased fluids, remember that you're increasing the systemic vascular resistance. And what did we say blood pressure was? Blood pressure is a product of what? Your cardiac output by your systemic vascular resistance. So ultimately the RAS system can increase the blood pressure. So someone with heart failure, it would also be a common thing for you to get to see edema in them, especially when it's right-sided heart failure. And even in left-sided heart failure, remember left to the lungs, it would be a common thing for you to see pulmonary edema. So you would hear crackles when you auscultate the patient. Anyway, all in all, what you should just remember when it comes to fluid dynamics, think about your hydrostatic pressure, and think about your oncotic pressure. Now, I believe repetition is the teacher of all masters. When you think about your hydrostatic pressure, think about your blood pressure. What have we said blood pressure is? Again, I'm repeating because repetition is the teacher of all masters. Cardiac output by your systemic vascular resistance, or just think about fluids in a given compartment. When you're thinking about oncotic pressure, think about albumin ultimately. So if you're bringing in albumin, what are you thinking about? You're thinking about the liver, you're also thinking about the kidney. Overall, any mismatch in this, you've got reduced hydrostatic pressure or reduced oncotic pressure and increased hydrostatic pressure. Forgive me again. You get to see that fluids ultimately will begin to seep out into the third space, leading to what is known as what? Edema. And of course, there's that grading of edema. So just remember grade 1, feet, grade 2, knees, grade 3, thighs, grade 4, generalized or, anasaka. Anyway, I hope that was a little bit straightforward. We're together, right? Alright, cool.